Hi, my name is Dr. Aaron Steen. I'm a board-certified dermatologist and Mohs micrographic surgeon. I practice at Dermatology Physicians of Connecticut. And today I'll be discussing a study comparing the results of a CP-GEP gene expression profile test versus 31-GEP gene expression profile test in the determination of sentinel lymph node positivity risk. The standard of care in dermatology is when a patient is diagnosed with a melanoma and we're considering whether or not to recommend sentinel lymph node biopsy, we generally consider anything with a risk of lymph node biopsy positivity greater than 5% is a worthwhile test to at least discuss with the patient. If it's over 10%, we typically recommend the test. What we found is that the majority of people who have a sentinel node biopsy have negative results. And so there's a space for patients who have a thin to intermediate thickness melanoma to have better risk stratification than simply staging alone. The technology that's emerged to help us with that risk stratification is called gene expression profiling. And there's two major tests on the market now that help with this. The first is called CP-GEP, and it combines gene expression profiling from 8 genes, I believe, and clinical pathologic features. The other test is the 31-GEP, which can be used either only testing the 31 genes in question, or it can be used both with 31 gene expression profiling and the clinical pathologic features. This recent publication, Prieto et al., compared those two different platforms. And the way they did this was they accumulated data from prior studies with follow-up showing which patients who'd had this test went on to have a lymph node biopsy that was positive versus negative. And what Prieto and his colleagues found was that patients who received the CP-GEP had a false positive rate of about 6 to 7%, which is above the cutoff that we normally consider. So, like I said before, based on staging alone, we have about a 5% false negative rate. And using that test actually increases the false negative rate to about 6.5 to 7%, which means that it's really not a particularly useful test in this context. In comparison, 4 studies of the 31-GEP, either with or without the clinical pathologic features included, decreased the false negative rate to about 2 to 3%. So that's that added benefit we're looking for in better stratifying patients with thin to intermediate thickness melanomas in whether or not we should be recommending sentinel lymph node biopsies. Now, I personally like this test, and I recommend this test to any patient who has a melanoma of 0.3 millimeters, Breslow thickness 0.3 millimeters or thicker, without any signs of metastasis. And the reason why I recommend this test is that the vast majority of melanomas that we diagnose are T1 or T2 melanomas, which are right in that threshold for people we may be considering sending for sentinel lymph nodes. And the vast majority of those people will have negative sentinel lymph nodes. And not only that, their survival is about 98% for T1A melanomas, which is great overall, but that still leaves a portion of these patients who have potentially life-threatening disease, even though they have very early stage melanoma. And so for those patients who normally would not receive a sentinel node, by using gene expression profiling, we have a better way to figure out whether or not these may be in that 2% that are higher risk for a life-threatening disease. Conversely, for patients who have higher stage disease, but may not need a sentinel node, these are people who I get the test for, and if they're found to have a genetically low-risk tumor despite a high stage, these are people that I may reconsider whether or not I'm sending for a sentinel lymph node discussion with a surgical oncologist. I like to use an analogy or a metaphor when I'm thinking about gene expression profiling and its utility. So I like to think of a melanoma taking a road trip. And the origin of this road trip is tumorigenesis. This is the initiation of this melanoma. The destination of the road trip is metastasis. And so, as doctors, when we're trying to figure out how far is this tumor from reaching metastasis, when is this tumor going to metastasize, we really need to know two things. The first thing is how far along that path is it already, which is staging. The second is how fast is it moving? And that's what I like to think of as gene expression profiling. So by using these two things together, we really have a better sense about how high is the risk of any patient's melanoma to becoming a life-threatening disease.